Hello there, my name is Kristen Connolly, and for my presentation, I decided to do Pender's Health Promotion Model. All right, so a little bit of background. Who is Nola Pender? Well, she is a distinguished and influential nurse. In fact, she's actually one of the living legends of the American Academy of Nursing, which is a pretty distinguished honor. Just quick history. She received her diploma degree from a local hospital outside of Chicago. She then went on to see her bachelor's and master's degree from MSU and her PhD from Northwestern. She taught at many universities, most notably Northern Illinois and Michigan, where she actually mentored many future nurses for over 40 years. So the beginnings to health promotion began while she was doing her doctoral degree. She began to see a kind of a switch in healthcare that was needed, most namely focusing on caring for illnesses to more disease prevention. This kind of enabled her to believe that health promotion and disease prevention should be the primary focus in healthcare. And she saw nurses as influencers and teachers in promoting healthy habits and believed the definition of health is not necessarily kind of an all-encompassing term for everyone. She believed that is actually very individualistic. So she basically kind of wanted this whole switch in healthcare. This is now considered a middle range theory. One thing I think that's really notable is that she just recognized that everyone's unique. So their confidence, their environmental situation, all that is very unique to the individual. And she really realized that making healthy changes is going to be on a personal basis, not necessarily health as kind of a whole, all encompassing term again. So there are three main concepts in health promotion. So this is a diagram from our textbook. There are individual characteristics and prior experiences, behavior specific cognitions, and effect. And then the last one is behavior outcomes. So basically, we can break these down even further. So, personal factors can be psychosocial, biological, it can be cultural. This means gender, race, education, socioeconomic status. Secondly, the first concept also includes prior experiences, so something that may have happened in some person's life, and also who influences them, their family or their community. Behavior specific cognitions and effect, that second column there. So, perceived benefits of action. What outcomes will this actually come and will they benefit me? How challenging will this be? Is kind of the barriers to the action. And then self efficacy. Can I actually do this myself? Activity related, kind of the fourth one down there. Feelings that are going to occur before, during the change, and then after the change. Next is interpersonal influences. Again, that's social support. And how are you supported when you're going to try and implement these change behaviors? Next is situational. So that's going to be your environment, and that could be positive or it could be negative. Lastly, behavior outcomes. So, competing demands, life challenges that maybe an individual has low control over. And then, commitment to the plan of action. So, a strategy that is going to lead to success. And then, lastly, health promoting behavior. So, actively participating in that chosen lifestyle of behavior. So, for my nursing phenomena, I decided, can we improve nutrition in the hospital and in turn improve outcomes, not necessarily just in the hospital, but also outside of the hospital? So, let's break this down a little bit. If we can improve and teach healthy eating in hospitals, it's possible we could improve necessarily there's like a length of stay. We could decrease that. We can also improve healing after surgery. This actually can mean multitude of things too. It can be undereating, overeating, or just lacking nutrition in what a patient is consuming and we are providing to that patient. And again, this can teach them in the hospital and then possibly also outside when they go home. So why is this important? Well, I found multitude of studies that poor nutrition actually leads to longer hospital stays. And one study necessarily said that they may be eating the right amount, but notice here 24% of patients in this one study had satisfactory protein intake during their stay. So only 24% were eating the right protein. Lastly, as I said before, it can improve healing, it can shorten hospital stays, and it can actually prevent immune suppression, which means that we can prevent things like hospital-acquired pneumonia. So, what can we do? We can do a nutrition screening to actually all patients when they are in the hospital. We can especially do education throughout their stay and upon discharge. This is kind of a key component here. So, continuing to do education all the way throughout their stay and with discharge instructions. We can also promote and advertise nutritional information. This is actually proven to influence patient decisions. So just like when you look at a menu sometimes at restaurants and you see the calories and that makes you make a change, we can do the same thing inside the hospital. And John Hopkins actually in this one study reduced hospital stays by over 3 days, which is huge. It actually saved over 1,500 per patient. So again, screening within 24 hours of being there, and then education, 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 which of course is one of the very key elements to the health promotion model. So this is actually from the University of Michigan's website. It is a clinical assessment tool that Pender herself created to promote improving nutrition. Now, while this necessarily might not be the best element to do right away when we are assessing someone for nutritional status within that 24 hours of being there, this could be something that we could do possibly before discharge. So seeing if they actually have an understanding of healthy options. Again, this can be under or over eating. So I think this would be a great evaluation. Again, we could adapt it, but it is something right there on the website that's really simple and easy to use, and it actually will give us an insight to determine barriers and how well they maybe understand nutrition. And we can download it right from the University of Michigan website. Again, this is probably more adapted to outpatient use, but I still think that we could use it before discharge. Again, remember the key here is beginning nutritional teaching in the hospital, and that could lead to better outcomes outside of the hospital. This is an easy assessment tool that is actually developed by Pender herself. So let's continue with some research and why is this important. So, research was very in favor of this health promotion model. In one study that focused on obese and overweight women, it showed that the model led to higher self efficacy and better nutritional control. So, this study actually focused on leading through like media channels, so kind of television ads. So, this is that whole thing. If we start and we can educate, if we can continue to educate throughout, even little parts like people watching TV and seeing a healthy ad can continue that influence on that person. Furthermore, I think it also shows that there's no kind of cookie cutter approach to this because cultural and family is going to influence patients' diets. Again, if we go back to that kind of breakdown, that is going to be another key element that we have to continue once that person leaves the hospital stay, where kind of everything is more cookie cutter in the hospital. We have to remember that their cultural and their family is going to influence them. The other study that I found was nutritional education to elderly. So basically, this kind of showed that there was a low cost tool that nurses can use to reduce mortality is education. It was actually able to account for up to 70% of elderly women making changes slowly just due to education. So I believe using Pender's health promotion model, we can slowly tackle these issues. Again, the key here is following that framework and identifying where we may have some problems and using education to help promote. Another research article I found was using students, nursing students, but I think this kind of proves one thing is that if you can teach healthy habits, they are going to roll over and teach those to their patients. This can be applied again to nurses, doctors, providers. So I think I have water here because that was one of the key elements of this is just teaching hydration. So hydration, water seems simple, but how many of us know that patients sometimes just don't drink anything and they can become dehydrated? So promoting, teaching, again, can roll over in teaching our patients. So key point here, is this possible? Yes, I think it is possible. I think it would be something that had to be broken down into different steps. This one article I found said a full assessment, of course, a full assessment is always going to be best, but a screening is beneficial. So, doing that quick 24-hour screening, figuring out where our barriers are, figuring out, is this malnutrition? Is this going to be overeating? So, is this going to be maybe a diabetic who doesn't really understand how they are supposed to be correctly fulfilling their diet? Again, having that kind of that breakdown, as we talked about, like a nutritional breakdown of carbs, calories. That was back a couple slides ago, but that was one of the articles that I actually found, is that if you can break down and people can actually see what they're eating, it's a great tool to be able to teach patients. And of course, not every hospital has that opportunity, but there are hospitals that break down all of their nutritional food. So I think teaching throughout the hospital stay for someone like a diabetic, but also making sure that we are getting enough nutrition for our patients that possibly are malnutritioned or aren't getting the correct, like I talked about, 24% of the patients with protein. So making that a higher number. So this is going to be key inside the hospital, but then it is going to be an interdisciplinary effort outside of the hospital as well. So we are going to have to use dietitians. We are going to have to talk with primary care providers to be able to help them follow up. And possibly, one thing I was thinking is maybe we could have a nurse that specifically follows up with patients and finds out what they need once they go home. What are their barriers when they go home? So this is, again, if we can do that full assessment before patients are discharged, I think that we are able to really communicate the right referrals or the right communication to their primary care providers or their providers that are going to be seeing them outside of the hospital. And here is all the different research articles that I used to create this PowerPoint. I hope you learned something. I hope you are able to understand better Pender's health promotion and how possibly it could help with nutritional status inside and outside of the hospital. Thank you.